And I know that others will join us, but I would like to welcome everybody to our 5th Deliver webinar. I'm on Wurundjeri country, the lands of the Kulin Nation, and I wish to pay my respects to elders past, present and emerging, and acknowledge the different lands that you're all on across Victoria and New South Wales today. We are delighted to bring you this webinar titled Virtual Care in the Loddon Mallee. And so thank you to our presenters, Professor Marc Budge and Katrina Neave, for sharing their experiences with us today, and to all the attendees for your interest and participation. So we will leave time for questions at the end, so please have them ready. We'd love to hear from you. So just a quick introduction to our speakers. So Professor Marc Budge is a geriatrician and Clinical Director of Integrated Care Services at Bendigo Health. Marc's research interests include the prevention and management of cognitive and cardiovascular decline with ageing and disease, the development and integration of point-of-care health devices and implementation of community-based health and wellbeing programs at the interface of technology, aged care and chronic disease management, so highly relevant to deliver. In the past 6 years, Marc has evolved a sustainable, scalable outreach telehealth service called Geri-Connect, and more recently, an emerging virtual care platform, including remote home monitoring across the Loddon Mallee region of Victoria. And Katrina is a digital health specialist at Bendigo Health, specialising in organisational change management with significant clinical, operational and project management experience in both sort of metropolitan and regional healthcare settings. So thanks very much for co-presenting today. I'll hand over. And I think, Marc, you're planning to speak for about half an hour, is that right? And then we'll have some time for questions. So.
Yeah. Unusually for me, I'll have the small speaking spot at the beginning and hand over to Katrina with the substance, because I think you'd like to hear what we've been doing in the Loddon Mallee, as the title suggests. So I might ask Katrina, since they're all in one slide pack, to share the slides with you. So I guess, as already mentioned, the origin of some of this work, and really it started as a clinical service delivery project, but always with the proposition in the back of my mind that what I was really interested in was improved health and well-being across the community for older adults. That was the goal, but it had to start from within the context of clinical service delivery. There's a little link there. You can have these slides later to a talk I gave 2 years ago now, when we did a virtual care talk related to older adults via the Centre for Digital Transformation of Health. It was a whole day, and I had the 2 presentations that I gave that day up there. So have a look if you're interested in that topic. But more importantly, there are also quite a number of other speakers who broadened out from the substance of what's the evidence that starts this conversation right through the delivery and policy and procedures that might follow. Okay, next slide. Thanks, Katrina. So where did we start from a clinical service? I arrived in Bendigo in 2014, having previously been at the ANU in Oxford before that. And I was looking at where were the gaps in service provision. And what became very, very evident was the most significant gap was any service of geriatricians, being my specialty, to residential aged care facilities or into the community, and particularly to smaller health services or small hospitals across the region. The regions are there, but Katrina will outline that a bit more later. What we then did was to look at what sort of model would we want to develop to deliver services to provide what the community was wanting. And it turns out to be a hub and spoke model, with those highlighted towns being, if you like, the hubs, and Bendigo being the largest of all, therefore the central hub. So we went through the initial steps as outlined on the right. That is, we went and literally did town hall propositions, where we went to every little place across this region and sat listening to local communities about what their needs were from a health point of view and a well-being point of view, and what they particularly wished for first out of those and how they'd like it delivered. We then looked to document, well, what were the service hubs, the referral pathways, the links to clinical governance structures, possible funding sources, how that would all try to tie together and fit together. So to help with that, we created a subacute services forum. Subacute is a word used to encapsulate geriatric medicine, rehab medicine, palliative care. It's not a word that I like, but it's very commonly used in Victoria, so I adopted it when I came here. So this is what the initial vision I had was, and this is very conceptual. not structural or operational. So what I really wanted to say was that we really need a common telehealth home monitoring and health informatics analytics enabling platform, literally across the platform. We wanted to address those needs which were most evident in terms of lack of provision of geriatrician services in stage 1. And so we started with first 5, then up to 15 nursing homes, providing telehealth services and providing that same thing to smaller hospitals across the region. So you could call that Geri-Connect in care, if you like. That was kickstarted with a bit of funding from Better Care Victoria at the time. But really where I wanted to come to as stage 2 were to address these issues: aged care at home, dementia diagnosis support, chronic disease and pandemic management, which turned to be a little bit prophetic because this was back in 2016-17, except that didn't get funded because they thought home monitoring was not something they wanted to fund. They'd fund telehealth just to see how it went. So we started with that, and we came back to this belatedly, and because we had to, because of the COVID platform we needed to develop. So next slide. So that was just how we started as a broad conception. But to do this, we realized that to have a sustainable clinical service model, you need to address all these things. And often people just think about, well, you know, let's solve the technology. Well, that's not the problem usually. That's actually usually the easiest part. It's the operational change, it's the change management of practice. It's recurrent funding sources, which we still don't have for many of these things in the community, digital or even remote patient monitoring for chronic disease. And I've been trying since 2007 to get that, never quite achieved it, almost did once with one Labor government. And workforce issues. What does it have as a workforce need? And what's the marketplace? What is the clinical market that we're actually addressing? How do we bring all those things together? Next slide, thanks, Katrina. So we worked on that and then started with Geri-Connect 1. And so now, as you can see on this side, we've gone up to, well, it was then 58 when I did the slide, nursing homes we provide services to. It's now over 60. And that's been successful and growth year on year, 10, 15%. But still, I wanted to get back to this side. And of course, as I said, that required the impetus of what COVID did for us. It developed some things, some platforms, some rushed solutions, but not necessarily ones that were optimal or ideal for maintenance or the background for the future. But nonetheless, it did that. And it also made some funding available. Next slide, thanks, Katrina. So in the meanwhile, while we're waiting for COVID and other things to happen, and during COVID and post-COVID, we looked at some of these sorts of propositions in terms of research propositions, looking at health and wellbeing in the home. I've mentioned Geri-Connect and the Telehealth outreach service. We also looked at a mobile app, NetHealth, and deployed that for chronic disease management across the community. Why? Because at the time, and still is, one of the only applications that actually links data collected in the home to general practice straight into their software. It's integrated into the 2 major software propositions for general practice. And so it could go both ways. The data could be seen in our service when it was integrated into our EPR or whatever platform we're talking about, but also it could be seen by general practice at the same time with the consent of the individual. But not everyone across the Loddon Mallee has a phone, a mobile phone that has apps or ability to do that. Also, not a lot of them also have the connections that they'd like to have in terms of their telephone connections. So we worked on a regional IoT platform that was not based with phones, no mobile app in the middle, a much cheaper solution for those also who wanted to be engaged, and demonstrated we could do that as well with one trial. And we'd like to do another much larger population involved, but certainly successful. In places where there was poor telephone connection, poor internet connection, we found that we got about 96% of the captured data actually captured and utilisable by staff, and a very high percentage of satisfaction by the participants. I won't go into this one. This is basically a pressure sensing bed. In other words, you lie on the bed, it's integrated into the surface of the mattress to try and prevent pressure ulcers, which is a problem for older folk, particularly housebound or bedbound folk in residential aged care, in ICUs, in subacute wards. and those who need to sit in wheelchairs most of their day. All of those people need to have advanced warning with AI and other things in the background. And we've had now monitors on beds in our ward, our subacute ward in Bendigo, for about 2.5 years, gathering probably about 70,000 hours of data. So a useful thing. And also the emerging issue of the role of digital virtual care agents to assist with the labour shortages that we all have and may have even more after this budget is eventuated from the State Health Department and Treasury. So a lot of those things were things we've worked on, just as exemplars. I won't go into more details today, but happy to at any time. Next one, thanks, Katrina. And where do we get to from there? Well, it's the joys of the Loddon Mallee, and it really is, when you look at those lovely pictures across the riverscape there. And this is where Katrina came to join us and is now the manager of our virtual care office across the Loddon Mallee and much more, but at least that I want to highlight. And it's been a delight to work with her to try and evolve all these things, which are really due to her and her staff's energies. And I won't talk more about it. She'll tell you all about it. So I'll hand over to Katrina.
Thank you, Marc, and thank you, everyone. It's great to be here. As Marc said, I'm the manager of the Loddon Mallee Virtual Care Office, and we'll do a bit of a run through for you in terms of the broader work, I suppose, and maybe zoom out a little bit as well in terms of some of the timeline and content. I'll, of course, start by acknowledging the traditional custodians of the lands. We're coming to you from Jaja Wurrung country, and it's a beautiful sunny day today, so it's wonderful to be here, and would obviously acknowledge the custodians of the lands that you're all coming to us from today. So the Loddon Mallee region, as Marc said, is a fairly vast area. We do cover 25% of the state geographically. It's around about, I think it's actually the 7 or 8% now. I need to update the slide in terms of demographically. So a lot of people, well, a lot of area and not so many people, but spread out. So the tyranny of distance is a really significant thing. We have 15 health services within that area that are set across 10 different local government areas. So just a bit of an overview there in terms of the actual region itself. So the high level in terms of the timeline, so Marc's covered some particular initiatives that have been quite rightly acknowledged as being, at the forefront of the work in virtual care across the state and indeed the country. But just to focus on the timeline a little bit within the Loddon Mallee to understand where that work fits. The Loddon Mallee actually has a really extensive history of collaboration as a region with the establishment of the Loddon Mallee, what is now the Loddon Mallee Shared Services, all the way back in 2006. So there's been a long held practice of collaboration at the CEO level and down, which was really driven by, again, that regional context and that the need to collaborate in order to be able to achieve outcomes. So not a new thing in terms of, predates the HSP model, for example. Part of that had been the contribution or the alignment of resources across the health services to create the architecture that then underpinned the ability to have a regional platform. The investment of that regional platform sort of formally commenced in about 2016 and kind of continues to evolve. And that's the timeline that aligns with what Marc was outlining as well in terms of the various pieces of work, including Geri-Connect, which obviously is going on strong. In 2020, across the whole state, there was the statewide telehealth project that many of you, I'm sure, would be very aware of. The outcome of that program of work in the Loddon Mallee was actually the recommendation of the establishment of a virtual care office. So that's why the virtual care office exists. Partway through that, there was the establishment of the Better at Home program of work as well. And that's important in our context because within our program of work in Better at Home, which was the first job I had within the Loddon Mallee, was actually the commitment of implementation of a region-wide system that allows remote patient monitoring in all of the settings across the region. So with the various numbers of pilots that have been quite successful, the work that Marc has just outlined, but also some work that was done in partnership with our local primary health network, there'd been these really good examples of, a proven concept effectively. So we wanted to move beyond that and move into operationalising the use of remote patient monitoring, again, in that chronic disease management space, but also looking to see how else we could advance that into the future. at some point during that pesky little COVID thing hit us all. And as I'm sure was your experience in a regional setting, ours was certainly one of a little bit of panic, I think it's fair to say, at that point where the system that was being offered in the metro setting was actually not being made available at the time during in the regional settings. So the response, and I'll talk you through that in some more detail in a moment, within the Loddon Mallee, we were positioned such that we could actually build our own and implement our own, which is what we went on to do, and we've continued to evolve ever since. And since then, again, I'll go through these in more detail, but we then moved into the implementation of remote patient monitoring, which was the addition of the clinical devices and beyond. So we're now in that space where we're looking to see where else we can take that, which is really exciting. And I keep losing my mouse. Even though it's, look how big that cursor is, I still lose it. Okay, hang on. So in terms of the COVID wave, particularly that Delta wave, as it was sort of surging outside of the Melbourne boundaries, what we needed at the time as a region was that single view of COVID-19 patients that were being managed in the community, a standardised clinical management plan for those patients, which was provided by the Department of Health in terms of these are the standard assessments, but again, the system that supported that was not available in the regional setting. A streamlined and timely process for managing the digital referrals from the public health unit all the way through to the health services themselves, which was a very paper-based and risk-heavy, just by the nature of the context, process at the time. The ability to manage demand across the region was also something that was highlighted. So we had, of our 15 health services, there was 3 in particular that had extraordinarily high demand. So by setting up the one system, it meant that there was the ability to actually alleviate where we needed to across the region, and obviously compliance with patient information security standards. So what we did, and this is a little while ago, but there was the decision to utilise the regional community platform, which we call RCP internally, to use that as the platform to be able to offer what we needed to our health services in terms of virtual home monitoring for our patients. And again, the focus was the patients who were in the community who were at most risk of deteriorating. So we undertook a process that was partnership with the vendor, obviously working very closely with the public health unit and with the health services to be able to consult as we needed to, and went from having a proof of concept to it up and live and running in 5 of the 15 health services, and within all 15, so 16 there, in the 28 days. So it was a really rapid implementation. And I think, you know, one of the reasons that we still point back to it is, you know, I know it's not something that you would ever really wish to replicate in terms of the never waste a crisis in the COVID setting, but I think it has taught many lessons in terms of what is actually possible when there is all of the right alignment across the board and the right allocation of, to be fair, what was pretty scant resources. So it wasn't a significant investment, but it was a lot of park everything else and get on with this. It was also informed by clinicians, and there was that, you know, quick release cycle that supported it, so we could continue to evolve it to the point where what the clinicians were looking at on by day 28 was vastly different to what the clinicians used in that first 14 days. So that continuous improvement cycle was obviously necessary at that pace. But what it provided was that ability, and again, referring back to we needed to have a whole of region view. This is an example at one of the more peak periods. I think actually, no, this was a very low period where we did have that ability to look at which of the health services and were they actually able to manage their load and be able to reallocate that if we need to, which was absolutely undertaken at various points. So that was using the system without anything in terms of integrated clinical devices. So once we had done that, the foundations were very much set to continue to evolve that, having already, you know, arrived at the position that through the Better at Home program of work, one of the objectives of that was to have that, you know, region-wide availability of remote patient monitoring. That foundation had indeed been set. So what we were then able to do was to leverage the funding that was available through Better at Home from an equipment perspective and invest that almost in its entirety to the clinical equipment and the integration of that clinical equipment into our regional platform. So what we have now, and this is a bit of a just a little drawing to demonstrate, but effectively with the clinicians at home, patient out in the community, we have the patient with an app, which is actually their patient portal. So it's not a specific app to remote patient monitoring. It is a patient portal into our RCP. We obviously have the biometric readings that then they Wi-Fi into the app, which then sends it through to the clinician. We also have the ability to send and receive messages, so the patient can initiate a message at any time. We're also able to send questionnaires to the patients, so we're able to have standardised tools that can be built as a survey and sent out. In addition to that, the biometric readings. So depending on the patient cohort, the value that you place on questionnaires versus biometrics obviously changes and alters depending on the cohort. In terms of benefits, I feel like I'm going to be preaching to the converted with everyone on the call, but this is very important in terms of our slide when we're engaging and communicating across the region, because it really is obviously around why are we doing this in the first instance, and really continuing to focus on for the benefits for the patients, for the clinicians, and of course at the system level. So ultimately, by focusing this in the first instance in the non-admitted setting for chronic disease management, there's a lot of focus there around the reduction of potentially preventable presentations to urgent cares and EDs, but we're also looking at through the implementation with hospital in the home and GEM at home, that ability to facilitate earlier detection of clinical deterioration. There's also, again, also in the chronic disease category, the increased confidence and in building of health literacy within patients and families also, and then building that engagement with the clinical team, and also looking at it from a service efficiency perspective. So for example, some of our complex care and heart services are able to visit patients less frequently if they're monitoring them, for example, and that's where we've seen it have the biggest impact operationally so far. In terms of our integrated clinical equipment, everyone always asks the question, so we've included this in terms of what we use. We actually went through a tender process, of course, and the successful tenderer vendor for our equipment is actually Propel. So I've included a link there. So we've gone with the iHealth devices, which will be familiar to many of you. It is very, very helpful to have the one set of equipment across the entire region. As a team of 3 people within the virtual care office, there's myself and 2 others, we are in a position to be able to continue to scale up and continue this implementation as a result of having just consistent, the system is the same, the devices are the same, so that implementation is obviously supported in terms of scaling there as well. We also went into a financial partnership with Murray PHN, who were able to contribute to the additional procurement of further clinical equipment at the time, which we were very grateful for. So just super high level in terms of how it works, the virtual care office sits within digital services across the Loddon Mallee. So we aren't providing a service as such. We are working with the clinical services within health services to adopt RPM as a tool. The patients remain under the clinical governance of the relevant health service, who also retain that sovereignty of their clinical data also. So we don't provide a central remote patient monitoring service as a team. It's more about that continued rollout that we support, and then ongoing expansion, additional development for improvement and those sorts of things. So the patients are actually identified and recruited by the clinicians within the local health service. There's a process then in terms of assessment, as you would expect, provision of appropriate information. There's a referral process internally just to get them onto the dashboard. The relevant devices are selected depending on their condition, so which biometric parameters you're monitoring. So it's rare that the patient would need all 5 sets of equipment. Patients provided with the devices, and they actually use that on their own phone currently. We are in the process of working through and providing some equipment for those cases where the patient doesn't have access to a smart device. Back to Marc's point in terms of the wonderful work that was done in terms of the study with the low packet information making its way back into the system. We actually haven't taken that any further at this point, but there is definitely, as Marc said, some opportunity to revisit that, because a lot of the health services and our communities, even in Bendigo, there's quite a lot of dead spots around. So that's an unfortunate reality that we're working with at the moment. Then it's up to the clinicians to manage that patient load from a day-to-day perspective in terms of the dashboard. So I'll just quickly show you, mindful of time. So just super high level, again, I'll provide these slides to everyone and happy for any follow-up if anyone is interested. But we do have the dashboard there that does have the clinical review, clinical status column there. So anyone who has readings outside of range versus people who haven't taken a reading versus people who have taken readings that are inside their range. We also have things like their messages that have come through. So you have a dashboard view of which patients have sent a message, things like tags for the ability to filter differently depending on your clinical service, and a few other points in there as well. And we've organised this based on their care type, so you can see that we've got diabetes versus diabetes in pregnancy, chronic care, that sort of thing. So that actually enables further filtering and for the system to behave ever so slightly different depending on the requirements of that patient group. In terms of patient experience and engagement, at the point of onboarding, there's what you would expect in terms of consent and all of the appropriate education, and then we support, as the virtual care office team and the rest of the digital services team, support the clinicians to support the patients. So it is about increasing that confidence and providing things to be as straightforward as possible for the clinicians to be able to troubleshoot with the patients, which is a bit of a working process, I will admit. In terms of broader engagement around the actual system development and the patient portal, for example, we've had a process of co-design with some of our consumers within one of our health services around how they, how that app looks and functions, and will continue to do so given it's the patient's portal. The intention with that design is that it's as simple as possible, giving us the most functionality but keeping it as straightforward as we can. So here are some screenshots actually of the portal itself. So you can see in here we've got the observations, there's the ability to view medications, and here you can see through this little tile here, once you open that one, you get the devices which can then be paired to an individual, and then patients just open and add a new reading once those are paired and they flow through. So our current participating health services are these health services that started back in November. And we're in the process at the moment of working with all of our HIF and GEM at home services across the region. So we've had a clinical leadership group who have been coming together since the end of last year as well to look at how we actually best implement this within the hospital, in the home and GEM at home setting, understanding that there are very different cohorts to the subacute. I know you don't like that word, Marc, I don't love it either, but of that non-admitted cohort also. So some really exciting work going on in that space. And we're also now confirmed for funding for this financial year to continue the implementation in the chronic disease management setting for the rest of the health services across the region that aren't already using it. So that will have us covering the entire Loddon Mallee. So all of our health services will have their community nursing or HARP, if they have one service, who are able to leverage this to be able to, again, focus on reducing potentially preventable presentations and hospitalisations. There's always other opportunities. We've really focused on trying to do simple very well and have it available equitably across the entire region. Once we have that, the intention is that we're able to continue to grow and expand. So we're looking forward to expanding into areas such as palliative care, community rehabilitation, potentially looking at adding additional devices and sensors in the home. But again, the intention is to get everyone using the basics and doing as much as we can with that before we get too carried away with ourselves and start looking, to get too complex too early. Obviously, there's an evaluation. You'll be very pleased to hear there's an evaluation plan. We actually are very fortunate that we have got a partnership with La Trobe. So we currently have a PhD candidate position open, which I will provide a link to if anyone knows anyone who is interested. We're also exploring through Marc and others potential connections with Monash with their medical student rotations to be able to potentially contribute to a broader program of work from that perspective as well. I'm conscious of time, so I'll finish on this one. So we have had a little bit of media out there. Bendigo is the biggest of the health services, and at the beginning of this year, I think it was, we had an opportunity to celebrate Natalie's journey, which has been a really fascinating one and just very heartwarming and wonderful to see. For example, she has COPD under the heart team in Bendigo, and she needed to go down to the Alfred and have an appointment with the transplant team, and was able to take in her patient portal and show them all of her readings and all of her results and be able to articulate what that meant and what happened when her readings were trending in a particular direction. She was able to articulate the action plan that was undertaken at that point, all from her patient portal that was in her hand, at which point the doctor took it out of her hand and said, "Where did you get this?" So that was wonderful. So I'm actually going to stop sharing. I do have a couple of other slides in here. So when you get the slides, if you have a moment to have a look, we do have a couple of patient stories in there with little videos as well, if people are particularly interested in some of that information to be able to see the impact on individuals. But I'll leave it there.
Fantastic. Thank you, Katrina and Marc. It was a really great overview of fabulous innovation in your region. So we've got lots of time for questions. So I will open it up to the audience for questions.
Do you want me to pick one?
Pick a person?
Pick a person? Alison, I think you were first up.
Sorry, I didn't have a question. Oh,
can you hear me?
Alison?
Oh, there's two
Alison.
Alisons.
Pick an Alison.
Is it me or the other one? Okay.
I think it was you. Go ahead.
Yeah, well, so I'm actually Grampians Health stall. I'm wondering if there's something like that coming to this area or for Grampians Health.
So I am probably not the best person to, well, look, I can only talk to what's happening in the Loddon Mallee. So at this point, I'm not aware of any extension of this beyond the Loddon Mallee, of this particular platform and approach. We've felt very, grateful to be able to tackle it as a region. Unfortunately, it sort of does stop there at this point, which is a big shame because I'd love to see a world where we're all doing the same thing. Wouldn't that be wonderful for our clients?
Yes.
At this stage, I can only talk to what's happening within the Loddon Mallee.
Okay, thanks.
I guess just to add to what Katrina was saying before we go to the next question, there's every opportunity to do that sort of extension or at least collaboration. And I've always felt, and that's the reason I moved to Bendigo actually, because I thought that the Loddon Mallee potentially represented a great test bed for things that then might be able to be generalised and used elsewhere. Or that others may have other ideas that might inform the model that we've started at Loddon Mallee to improve it. So I think that's the real opportunity and why we should all talk despite what happens, or in fact, independent of what happens from an evaluative or funding point of view from the department. We're talking about a much broader proposition which involves predominantly the community, not just what happens as if you like, the want of a state health service. Wendy, I can see a hand up.
Yep. Hello, Wendy Chapman. Thank you for that great presentation.
Hi, I didn't realize it was you.
Hi, Wendy.
Hi. Really excellent. And I wondered about the clinicians who are looking at the dashboards. What type of are they, and how does the dashboard viewing fit into their workflow? Do they feel risks about missing things? And also model, is there any, I don't know, financial model for them in looking at it?
Yeah, it's a great question. So it does depend on the clinical service. So with the non-admitted cohort, it largely sits in Monday to Friday services. So our HARP and complex care services, for example, and being that the model for those patients are that they're provided pretty extensive education around if they do deteriorate, they need to go to their GP. So that obviously continues with the addition of the monitoring. So the monitoring doesn't adjust that plan. So in those settings, it's a daily review of the dashboard. There is no direct compensation for just reviewing a dashboard if there's nothing untoward. However, if they do have a patient with a reading that's outside of range, if they've got, a VINA referral open or a CHISP or however that patient is funded, they are actually able to claim for the time that they then spend following up or actioning that, which can include sending a message through the platform. It could be sending someone out for a visit, it could be a phone call. So all of those activities are then able to be recorded and, a stat created for that activity. There is, unfortunately, as we all know, no direct funding model supporting directly virtual care. The other part of that is the hospital in the home and the gem at home. So we're actually undertaking some work. So we're yet to implement for those services. One of the things that we're still in the processes of testing is exactly that around the notification period. So one of the things that our clinical leadership group focused on quite heavily was that deterioration and the detection of deterioration in the inpatient setting. It's our regional community platform. So in the hospital, in the home and gem at home services, this isn't the platform that they're on every day and doing other things in. Our community teams are using for the documentation and for scheduling, those sorts of things. So rather than have to have eyeballs on a dashboard to monitor a hospital and home patient, and understanding that that's a very different context and their higher acuity and would be more likely to deteriorate after hours or in hours. So we've actually gone through a process where we're going to have an overlay of a dashboard, a Power BI dashboard that will actually fire SMSs when there isn't an outside of range. So there'll be, live dashboards there and available, but they don't need to be continuously eyeballing them for that reason. So we're going through that process at the moment to test that, to ensure that obviously each of the health services need to sign off that they're happy with that turnaround time and using SMSs and things like that.
Oh, thank you. Could you also say the number of patients that are taking remote monitoring?
Yeah, at the moment, I should know the number off the top of my head, but it's in between 200 and 250 at the moment.
Anna.
Yeah, Anna.
I'm not sure, are you on mute, Anna? I can't see a mute, but I can't hear you either.
Is that any better?
There you go.
There you go. Thank you. Sorry, Marc, did you want to add anything in answer to that other question first?
Oh, no, I was just going to little quick snippet to Wendy's thoughts. Obviously, part of the reasons for asking are the medico-legal implications of monitoring and someone missing an abnormal result. Essentially, because of the lack of funding and therefore the lack of staff dedicated necessarily 24/7 to this task, the reality is that usual care is what's being offered with this as an addition at the moment. A potent addition, but nonetheless an addition, which more looks at trends over time rather than necessarily being the only thing that might cue someone to go and visit a medical or health professional of any sort, or ED or whatever. So just wanted to make that point that at the moment, just as Katrina said, at the moment, we're really having, it's an addition rather than something to be relied on absolutely 24/7.
Thanks very much, both of you. That was excellent. And I just note, in case not everyone's seen it, Karen's put a couple of comments in about the Grampians health journey. I don't know if you want to speak to those at all, Karen, but I did have a question, Katrina. I thought it was great how you were describing the digital services team. And I just wondered if you had any reflections on things that you'd found you needed to kind of roll out once you had that team up and running and trying to support at scale, as you say. Like, was there any particular training for clinicians or consumers, or was there any infrastructure that you've found, you can do from that sort of central support role across the region?
Yeah, it's a really good question. I'm not sure that we've solved it necessarily. I think we've had quite good buy-in across the region. And what we did in the first instance was there were some services already using standalone remote patient monitoring platforms. So they had existing practices in place that we effectively needed to transplant out of the system. and, you know, at no cost. So that was a good news story for many as well. We're still in that phase where we've got health services sort of going, us next. So we do have that engagement. I think it will be very interesting to see in the coming months what sort of, you know, continues to evolve in our collective settings. My view, of course, it's my view, but I think they can't afford not to be doing this. So that will be the approach there. I think keeping it as simple for the managers and the clinicians as humanly possible is really important. Sometimes it does build a bit of a rod for our backs, but it's really important in the design. It's important in the implementation from engagement to evaluation. There's a constant thought process around how do we make this as simple as possible, but importantly, as simple as possible for the clinicians, really. Patients, yes, of course. But when it is the clinicians who are ultimately choosing whether they put someone on monitoring or not, that's so important. So we're in the, I do believe, fairly enviable situation where by using a regional platform, we don't have the situation where we're needing to constantly justify numbers and therefore financially chase our tail to be able to show evidence that we're using the monitoring enough to be able to justify the cost for the monitoring. I can't sit here and say how to replicate that. I'm sorry. I feel very fortunate to have stepped into this situation where it exists. I do see in that comment around, you know, Phillips withdrawing. I know, you know, Barwon have had a very similar thing, I believe. So it's a very unfortunate situation. I know I've tried to write the business case. It certainly doesn't write itself. So I think that's potentially the opportunity to look at, you know, we've got two partnering, you know, neighbouring regions, both neighbouring ourselves, that, you know, I think there is really opportunity there, because particularly for, you know, not to speak on their behalf, but I know within the Barwon setting, having existing programs that clinical programs that use remote patient monitoring and then having the absence of a provider is pretty dire, especially in this setting. I'm not sure if that answered your question. Yeah.
Yeah, I guess the other thing I'd add to that too, Anna, is that, and Katrina's already said it earlier, one of the keys to all of this evolving is that centrality of clinical governance and the fact that it came together years ago with a lot of effort, I might add, and getting all those health services to agree to any, shall we say, individual decision always takes a bit of convincing. But it has been critical, just as Katrina just mentioned, the criticality of having that central platform to which everything can work as a hub and spoke, as long as everyone's agreed that that's the good proposition we should all join. Once again, like many things, as I said earlier, there's no reason why that can't evolve more broadly than just here. For instance, when I started Geri-Connect, I was approached several times to actually use the same model to do that, quote unquote, why don't you do it across Victoria, Marc? Well, we could have, but I didn't feel that it was appropriate, because I actually believe relatively in a local model that operates and affects locally. Sure, you can do the basics of what you do in a telehealth consultation from anywhere, but it doesn't have the secondary value that being embedded within that health system also then provides, because you know the resources you can refer people to, you know how it works in that region. Now, the good news about this is that the Grampians and Loddon Mallee are not that dissimilar. Okay, they have different names for cities and towns, but yeah, that can be worked on. Horsham's not that different to some other places we've got in Loddon Mallee, et cetera, et cetera. So I think, you know, these things can all be looked at in terms of what the key infrastructure is that might underpin a successful manoeuvre to generate these things. And I guess the other thing I'd like to just emphasize while saying that is that, as Katrina said, we've emphasized a lot about vital signs monitoring because that's what happened out of COVID. My original aim, as I said right at the beginning, was to also look at supporting people in their own home with environmental sensing. Have they opened the fridge today? Have they walked outside their door? You know, can we support people with dementia in their homes and know where they are? All of those sorts of things are very simply done with IoT and other things, all of which we've demonstrated we can do. It just needed a platform on which to be seeing what was happening, or more importantly, to feed back into the arena where it's most needed, that is within the community, within the family, or sort of shared units, and how people live socially. So the reality is that, and I think that's worth keeping in mind, as opposed to what seems to be a plethora of things that have, if you like, grown from COVID, which just spin like a vortex on their own and don't have connectivity that helps do something for the greater whole in terms of health and well-being.
Thanks, Mark. Does anyone else have a question? I can't see everybody on my screen, so if you don't know how to use the raise hand, but you have a question, feel free to unmute and jump in.
Yes, I have a question, Catherine. So in order to, like when you introduce this platform and how you guys educated the staff members, like you might have come across some of the roadblocks, like some staff members might be digitally savvy, and some staff members are like they're also like they don't want to digitally not enabled or switched on. And also, like, just think we have trained a staff member or a team to support Geri-Connect, and then at some point they left the organization. So those skills, have you like come across these things, and how you manage that?
I think the latter one we will always have as a factor within healthcare and probably other industries. There's that painting the Sydney Harbour Bridge analogy, isn't there? Just when you think you finish, you have to start again. So I think there's an element of there needs to be simple education that is easily accessible, that is continually up to date and easily able to be shared and accessed at a basic level. You're right, there is always going to be also variation in terms of people's capability, I suppose, and experience and desire to really want to learn. From a change management perspective, it really is, we've focused a lot on that, fixing that desire thing, because if people really want to be able to do it, they'll do the work and learn. They might need extra support, but if they're being forced to do something and they don't have the desire to, that's when people will just give up and not do it. So for us, those patient stories have been really important. And again, we're in that fortunate situation where we don't have to push target numbers. So we've got some of our health services that have got 2 or 3 of the 6 or 7 coordinators who really value it and are doing a great job. So we're capturing those stories and those examples as we go, or doing our best to, so that we can actually demonstrate that back to the clinicians, because once they're sold on the why, then the how becomes an easier proposition. So if you've got that combination of really accessible, straightforward, and you're right, there'll be some people that, but if they really want to, they'll ask the person who's trained up a bit more, or has been, or reach out to us. As we scale up, we're really aware that we're not going to be able to provide that. We can't physically provide at the shoulder for anyone really at the size of this, the area that we cover, but we are available, virtually where we need to be. I think that addressing why really it's a bit of a sales pitch, honestly. And for clinicians, that's, what is this going to mean for my patients? Why would I do this? Is it very quickly gets seen as something else they have to deal with? And it is actually positioning it in their thinking that this is something that would be beneficial, selling the benefits really.
And in terms of sales pitch, just to give you an exemplar, Ishan, we have registrars that come from Melbourne to rotate up to Bendigo, and they get training when they come to see us in telehealth, some of whom have never done it before. And even though they spin out and go back to Melbourne, they're now trained users who have found that skill base is valuable, to the point where we have more people wanting to rotate to us, because not many other people are providing that, if you like, in-person and fairly intensive training. And so it has a value both internally as an attractant, as a magnet for staff, potentially, and also as a general value for those who rotate through to take back to where they came from.
Wow, nice. Thanks, Mark. Thanks, Catherine.
Thanks. So we're nearly at time, so I might just ask one final question before we wrap up, and then of course we'll have the slides that we can share with everyone today, and if you want to get in touch with Marc or Katrina, let me know and I can connect you. But Marc and Katrina, Deliver is an MRFF funded grant, as you are aware, and one of the goals of that too is to strengthen academic and health service partnerships. And throughout your presentation you mentioned a few of those sort of academic partnerships that you've got. Could you tell us a little bit more about how you've engaged with the academic sector to progress some of this work?
So we have got a formal arrangement with La Trobe in the sense that there's funding available for a scholarship for a PhD candidate. As I said, that is open, so it's very much early days. So we have an evaluation sort of framework that's been put together, but we are this is an area that I would absolutely love to see a greater level of partnership. I personally don't have a strong history in research. Marc obviously does. And we do have a lot of talent within the area, but certainly something that I personally think would be of a great advantage to be able to align where we can.
Yeah, and I guess just to mention two other names of universities as well, Melbourne and Monash. Obviously, there's a strong presence here at the Rural Teaching School. There's a new drive here to promote a greater research opportunity, both at the student up to the consultant level. So I think the engagement wish is certainly there. The opportunity is obviously available, and I think we're very welcoming of it. And we're at a stage in this sort of development, as you've heard, where it's time, as Scott Whitlam once said many years ago. It's time for us to actually look towards those engagements, collaborations, and more importantly, evaluations. I know when I was talking to the person, I've forgotten her name now, from Victoria University, who does your evaluation or leads your evaluation work, that there was a great opportunity in that with Deliver. And I think there also is in this process, even if it's one to inform what you're doing more directly with Deliver, to grab the, if you like, the truths of what's happened with us, and then to utilise those to take them forward or to change, as I said. So I think, it's that matter of communal learning, communal collaboration. It's always been one of my strongest interests to collaborate over many, many years. So the opportunity's there anytime.
Thanks very much. Well, thanks again for sharing your innovation with us today, and we look forward to hearing from you again in the future. Thanks everyone for joining us.